you, Mr. Chairman. Now I'm going to defend the medial pivot knee. Is it the way forward? The design of total knee are evolved by time to imitate the natural knee kinematics and the kinetics. The challenges of total knee replacement is to achieve perfect implant, and we know that only 80% of the patient are satisfied, and we exhaust our studies to know why they are not satisfied from this. We know that in basic principles of primary total knee replacement being told by John Insall himself, and one of them is the implant selection. And we can see here he's holding a posterior total knee replacement in his hand. The success of total knee replacement has been measured over time by the pain relief and the survivalship analysis. However, durability does not reflect function in all times. And Nobel in the year 2002 in the clinical orthopedics has studied the functions after total knee replacement, and actually found that in all functions are less than the natural knee. And he concluded from this, he said, this suggests that significant improvement in the procedure and the prosthetic design are needed to restore normal knee function. Why should we change? Because the patient expectations are higher. More patients want to participate sports. Up to 20% are not happy, and we need a normal knee motion and a normal knee function. If you can look to this from William et al. In JBJS 2002, is quite clear that the medial condyle of the femur is very stable on the medial side up to 120 degrees of flexion. After this, it translates a bit posterior. And here on the lateral side, we can see that the lateral femoral condyle, it moves backward for about nearly 1.5 centimeters. And this is a normal knee kinematics. And if we can see here the normal knee kinematics, we can see that on the left-hand side, at 0 degree, there is a screw home mechanism, and the anterior position of the femoral condyle. From 0 to 90, there is a medial pivot. From 90 to 155, posterior translation. And if you can see here in conventional PS total knee replacement, there is no screw home mechanism at 0, and the posterior overhang from 0 to 90, lateral pivot, paradoxical translation, and abnormal axial rotation. And if we can see here between the normal kinematics of the knee and the guided motion of the knee, or stabilize the medial condyle of the knee, we can find that at 0 there is a screw home mechanism, at 90 medial pivot, 90 to 155 there is a posterior translation. It actually looks like the normal kinematics of the knee. BS design philosophy, like Insall, Perstein, posterior cruciate, or PS of all the design of the companies, there is a central cam, and this central cam will allow for the femoral rollback. And the problem of the PS, when implanted, the rollback, why they were designed, does not occur. And usually there is a paradoxical movement, which is a slide forward. And we can see here fluoroscopic analysis has shown abnormal kinematics during knee motion, which is the paradoxical movement. We should agree that all total knee replacement are ACL deficient knee. We should agree for this. And because we are talking here in a society of arthroscopy, we know about ACL. And usually the tibia translate forward and the femoral condyle translate backward. AB stability in conventional PS, we can see the normal knee here, and you can see there is about 2 millimeters just between the condyles of the femur and the tibia. But if we can see here in a conventional PS, usually the femoral component in a resting extension position is overhanging posteriorly, or actually the tibia is translated anteriorly, because this is an ACL deficient knee. We can see here in the x-rays on the left-hand side and the right-hand side. On the left-hand side, this is a conventional PS, and we can see the posterior translation of the femoral condyle in relation to the tibia. And the lower one here is a medial pivot knee, and we can see that in extension, the posterior condyle is going like the normal with the tibial condyle. On the right-hand side as well, we can see here, this is a PS. One can see the posterior condyle is hanging posteriorly, and here in a medial pivot knee, it goes with the posterior component of the tibia. This is an early postoperative. We can see that there is some air inside the knee, because this is an immediate postoperative X-ray, and the surgeon is the same. I did the 4 cases. The philosophy of design, it is ball and socket. So the medial femoral condyle, the conformity of the radius of the medial femoral condyle with the conformity of the radius of the medial tibial insert will bring stability to the medial side, and it will allow some motion on the lateral side. As we can see here from the diagrammatic view of the medial pivot knee, it is a single radius with smaller radius very posteriorly to allow deeper flexion. The advantage: better stability, better range of motion, replication of the screw home mechanism, less wear, longer polyethylene survival, no paradoxical movement. As we can see here from the kinematics between the normal knee, PS kinematics, and the medial pivot kinematics, we can see that the medial knee kinematics is more or less like the normal knee kinematics. However, the PS kinematics, no screw home mechanism, lateral pivot, paradoxical translation, abnormal axial rotation. Does it work in reality, in vivo? Yes. This is the support of the publication. We can see in this publication significant advantage over the PS knee in the term of WOMAC score. In another publication from the Journal of Arthroplasty, we found that the patient who underwent medial pivot total knee replacement scored better on the forgotten joint score than those underwent PS total knee replacement. Another publication here which says a visual analog score for pain is significantly better than the PS. Another one publication here as well, superior patient satisfaction and patient expectation from medial pivot. Medial pivot prosthesis, better functional score and lower complication rate than PS. The medial pivot prosthesis can produce the patellar clunk or crepitus. Another publication here as well from the arthroplasty, kinematic and the kinetics difference between medial pivot and the PS, and it's better, significantly better in medial pivot than in PS total knee in all gait analysis phases. From that, we can conclude that medial pivot design provides better kinetics and the kinematics over PS knee, better functional out score, and the medial pivot knee could be the way forward to improve our results. Thank you very much.